Good morning, everyone. Nice to be here, as always. The time is really short, 10 minutes I've been told, so I apologize that I will have to rush. I'll try and share with you very briefly some experience and again, very briefly, some reflections, some thoughts, because I think that could be useful in this type of workshop. First of all, as you all know, in Greece, mainly refugees and migrants come through the sea route to the islands, to the, in the eastern part of the country. After that, they move to the mainland, those who can do that. Numbers, about 20,000 have arrived this year, about 170 last year, and more than 800,000 in 2015. Really a very large influx of migrants. This is the age, the basic demographics, which means about a bit less than 40% children. Sorry to go so fast. Syrians, people from Syria, Iraq, Afghanistan are the major nationality groups. At this point, it is estimated that about 45,000 people are in this country. There's still influx in the country. Quite close to scenario 2, I think, of yesterday's exercise. Where do they stay? There are hosting sites or camps, mainly organized and unorganized at the beginning. Actually, now they are all organized, and also there's a move towards apartments and hotels of a number of them, but so there's still a mix, a bit total, about 15,000 are in these places, which means about 1/3 of what there is. So, when the borders to the north of the country closed in 2015, people used to stay. As I said, when we had 800,000 people coming in, the great majority of them left for other countries through the northern borders. The northern borders closed early 2016, and this created a huge problem in this country. So at that point, it was decided to implement a syndromic surveillance system in places where these people, refugees and migrants, were staying, complementary to the existing one. We had quite important, at that time of crisis, I would say, quite important support from ECDC and ISS, Italy, Silvia in particular, and we are really grateful for that. We carried out a risk assessment, what sort of diseases are likely to happen, and so what sort of diseases we should include. I will show you. This is the form. I thought that the fastest way to go through what we did is by explaining the form. This is the reporting form. I'll take it bit by bit. There are two types of diseases, table A disease, syndromes rather, and table B syndromes. What is the difference? Table A syndromes are syndromes for which aggregate data is sufficient. And what we want to see for these, I'm not going through, I hope you see, isn't it? Yes? For table A syndromes, aggregate data is enough, and what is the objective of surveillance is to see whether there is a trend, an upward trend, indicating a possible outbreak. Whereas table B syndromes are related to diseases that are already in the mandatory notification system, and in a way, it is a sort of enhancement of the mandatory notification system in which we would require case-based information, not just aggregate, such as suspected pulmonary tuberculosis, malaria with positive rapid test, suspected diphtheria, etc., etc. You can see all the syndromes, again, I repeat, related to diseases severe enough to be part of the mandatory notification system. So that's how it looks like, a better view. So people have to, each day, from each clinic, let's say, have to fill in the number of people they saw, they cared for, and for table B, table C should also be filled in, which is, as I said before, some case-based information. Table D gives us a denominator. Ideally, we would like to have the second line of table D, that is number of persons in the center on that day, but this was nearly always not available, so we relied on total number of clinic visits in order to have proportional morbidity indices. On the back side of that form, case definitions of this type. Take rash with fever, either A or B or both. And this pattern of either A or B was for all syndromes. Fever, blah, blah, and at least one of the following rash, etc. Or B, clinical suspicion of measles, rubella, chickenpox, scarlet fever, or other rash illness. So, including the B part means relying more on the clinician's sense and feeling about what was the case. It is a small step away from what we are used to in terms of case definitions, where usually we use the A part. We thought that in a context like that, this would be more appropriate, and relying on physicians' judgment would be more appropriate. You see also the example of jaundice. So, at first, we piloted the whole system, and we started implementing it at mid-May 2016. Hosting sites ranged from 31 to 51. The trend is downward because, as I said, there's more and more relocation to apartments and hotels, and quite high participation, which is based really on a very close collaboration with NGOs, mainly running the clinics. This was really very important, very valuable experience. I'm not expanding this. We could have a whole workshop on that. Daily analysis of data. They take this form, a graph, having the upper confidence limit, the red line, and based on previous observations, and also the observed number of cases. In this case, you see this blue little dot means a warning. So we had warning and alerts. Alert was a warning in 2 consecutive days, and a warning observed more than 2 standard deviations of expected based on previous experience. A weekly report was released, both in Greek and in English, and summarized, had several pages showing graphs and tables and a good summary of what is going on. We should not forget that syndromic surveillance is really labor-intensive. It requires people in the field who do hard work, pressed, overwhelmed often, to do a little more, which they don't often, they sometimes don't understand, and I respect that completely. Priority is for the care of the persons, and also quite a lot of workload for the center, let's say, for the center that collects this. Just very briefly, a summary table of 1 year's experience from mid-May to mid-May. The only thing I want to show you, nothing not expected according to experience in other countries, infectious diseases, syndromes related to infectious diseases for which surveillance was there accounted for about 6.5% of the whole of total visits. Please keep this in mind. Of course, upper respiratory infections was the most, etc., etc. You can see these. I don't really want to go through that in more detail. So, main conclusions. No major health event was seen. More common syndromes reported: respiratory infection, gastroenteritis. Specific problems that we had was varicella and hepatitis A and scabies, and these were the main issues. Not really very severe health problems. In indirect effects, we were able to confirm that there are no major problems, and that was a very important reassurance. In my view, this is maybe the single most important effect of surveillance, okay? The indirect one, that we can say we know that there is nothing. It's not just that we think or it's anecdotal evidence, we have evidence for that. Raise awareness of practicing physicians to the conditions for which they have to report on a daily basis, and establish a communication line which was used for other issues as well, quite often, for other issues unrelated to the syndromes we included in our system. Now, a few things to reflect. I'll be really brief. I hope you can read faster than I can speak. So, issue number one, let's think about point-of-care surveillance or syndromic surveillance. We have the feeling that we should move from the concept of syndromic surveillance to the concept of point-of-care surveillance. Why? For two reasons at least. First, there are more and more point-of-care tests. For example, rapid test for malaria is really diagnostic. We can have the sensitivity and specificity of these tests is really very high in all studies that have been done. So we can have diagnosis at the point of care. The important thing with syndromic surveillance is that it's fast and it can happen right away without having to refer the patient, etc. Second, enhancement of mandatory notification, as I said, was also part of that point-of-care surveillance. Second point to reflect, case definitions, strict versus room for clinical judgment. I said about that, I'm not going to say any more. What are the signals produced by the system? We use the terms warning and alert, and not alert and alarm, which is a terminology usually used quite often. A large number of signals were proved not to have public health significance. We think that it is more appropriate to play down a little bit, which is more adapted to the real situation, to play down a little bit what is coming out of the system. And also, this is important because we are not doing this in the four walls of a room. This is public reports, and we are saying in a public report we have an alarm or an alert, etc. So we don't want to give wrong messages. Hosting sites, based on hosting sites, also, that is camps, mainly camps, or also in alternative accommodation, such as apartments and hotels. That's an issue that should be very, very clear. In our case, we thought the regular surveillance system would capture morbidity in the latter, and so we focused on camps and only camps. We also, our experience is that there should be periodic adaptations, changing constantly. The situation changes, experience is accumulated, so we should beforehand have a system to adapt. We were not very good at that, I must say. Another issue, surveillance bias. I call in this presentation surveillance bias. When we have surveillance, what we gather, the information, implies, or very easily people think that these are the important diseases. These are important from some points of view, not from all points of view. That is, it is important in order to realize a potential outbreak quick and act on that. It does not necessarily mean that these are the most important health issues of the people. We all know from studies that have maybe presented here as well, that other issues such as chronic diseases, chronic diseases or violence or sexually transmitted diseases can be really very important. Point to reflect on. Do we need a complementary health monitoring system? The issue came up in the discussion yesterday also. A final issue, when to stop. Not resolved yet, we haven't stopped, and I think we share the same experience with Italy. And it's not easy to stop something once it is there. And I think people should think beforehand on this issue. Otherwise, we may find ourselves trapped. Fortunately, in this country, as I said, the number of camps are going down. Fortunately, alternative accommodation types were not included initially in the surveillance system. So when camps are not there, the surveillance system will not be there either. So, points to reflect on just that. I think this is interesting. A sculpture in Karatepe camp, which was inaugurated a few days ago, called Solidarity, one hand supporting another hand. Thank you. Questions or after all presentations, what is the plan? No, because we have time. No. Now? No.
Is there any question? Yes, Silvia.
Okay, Takis, thank you very much for the presentation. Very, very nice. And while you were doing, I thought to ask you as question that at the end you put in the issue to reflect. I completely agree that are the point that came up, because in Italy was exactly this. Most of the point was exactly the same. And I think that probably we need to really write down these points because until now there are all the documentation saying how to build a surveillance syndromic system and the good things of the system and why and so on and like that. But with the experience that we had, we need to tell also these points, because for example, the first point you put that one of the most important, one of the most important effect was exactly the same in Italy, because running the system and having the results that we can provide to the media and was one of the best results of the surveillance, because we knew that infectious disease was not important, but we had to prove and to document this. So that is one of the best results. That is fun in a sense for setting up all a system for these results, but it was good. So I completely agree, and I think that we need to write down and to document alternatives, pitfalls, indirect effects, and other things. Absolutely. Otherwise, everybody will go through the same things and the same way. So.
Great, thanks. We have another question, comment here. Yeah.
Thank you, Taki. Very good presentation. Two questions from my side. Regarding the feedback to the reporting physicians or the reporting agencies, have you been providing the analysis of the data you've been doing to the camps?
Well, it is a public report. The weekly report is a public report.
The weekly report, though, is for all camps together.
Oh, right. Yes, I see what you mean.
This is per camp.
For the data for the specific camps. No. We thought this goes under confidentiality and could raise quite unsubstantiated, excitement and discussion about that, because it's really, first of all, at the camp level, although we did analyze the data every day at the camp level. And by the way, this was done automatically because it's a huge 50 camps by 14 syndromes, you can imagine. So we did analyze and we took action if there was something above the expected, but given the small numbers and the ease with which these could be misinterpreted, we did not give them to either public, we did not make them public, or did not give them to the camp level. We just, in a qualitative way, communicated the problem when there was one.
Okay, so my next comment comes because of that. So in the health coordination meetings we've been doing in Thessaloniki, for example, that was on a weekly basis, there was no feedback regarding the morbidity, the mortality, the types of diseases, what we would expect. And for NGOs that we are not part of the UNHCR as implementing partners and we don't have access to their databases, etc., it was impossible for the other organizations to follow up and understand what is the situation in the camps, if there was a need to do something extra. The way that the health coordination meetings have been organized in some places have not been the optimum. So at the end of the day, we were a little bit blind on the field regarding what is going on per camp and what are the extra actions that need to be taken. And this is in conjunction both with a lack of reporting from KELPNO to the NGOs and the low quality of the health coordination meetings on a field level.
I think this is a very good point. We should discuss it a bit more, what could be done, but I'm convinced that formal reports on a camp level is not a good idea. Furthermore, we were told that at the camp level, people at the camp knew better than we did what is going on there. So I'm not quite sure this would be helpful on top of their experience. But indeed, I accept this can be a very fruitful discussion.
Thank you. If I'm not wrong, yesterday your colleague from KELPNO said that the idea was to step by step empty the camps and shelter the refugees in the other places, like hotels and other places. You have this data from people that are sheltering in the camps. But
That's
when
right.
the people is going to be in other places, how you are going to manage this data? So you are going to separate refugees from the other Greek people, or you are going to manage like a whole?
Quite. This is a good question. I tried to, it's the final point here. We are going, the goal is to capture, let's say, morbidity in people living in apartments or hotels through the regular surveillance system, either mandatory or sentinel surveillance systems that function in this country. And in these systems, there is a sort of a box to be filled in about the ethnicity of the person, the country of origin. So we will have some information, but it will not be an ad hoc system. It will be within the general, regular surveillance systems. That's right. Exactly. Because they also care, health care for them is provided by a large number of health services. Most of them are the normal health services, the local health center, let's say, which is for all people. Or at least this is the idea.
Thank you very much. I'm sorry, can you... can you...